Ready? Okay. Good morning, everybody. Today we'll be talking about acute coronary syndrome. And the objective of this education video is first to identify patients with acute coronary syndrome. The second objective is to outline the acute management of unstable angina, non-ST elevation MI, and ST elevation MI. And after that, we will be talking about reperfusion interventions, meaning the cath and the stents. And then we'll go briefly over complications of heart attacks and how to manage them. So when we move to the next slide, it's case number 1. It's a 64-year-old guy with diabetes, hypertension, who woke up with chest pain, went to the emergency department 1 hour later when pain failed to resolve. So the first question is this patient at risk of acute coronary syndrome? Remember, the first objective is to figure out which patient has the right setup for heart attacks. And so we want to, with this, the first question is to figure out whether this patient has the right setup to having a heart attack. And then second question, do his symptoms suggest acute coronary syndrome? And the third question, what information is needed to determine the type of acute coronary syndrome? So let's go over the first question first. Does this patient have risk factors for acute coronary syndrome? So typically, as we know, the risk factors include male gender, age, diabetes, hypertension. And there are some other risk factors. This patient he's male, he's old, he has diabetes and high blood pressure. So his chest pain very likely will be related to a heart attack of some sort or acute coronary syndrome. There are other risk factors that were not mentioned in this scenario, such as hyperlipidemia, smoking, family history of heart attacks or MI at early age, obesity, sedentary lifestyle, vascular disease like peripheral vascular disease, cocaine use, and amphetamine use. So even in young adults with cocaine use, they can still have heart attacks. Just keep that in mind. So this patient has the right setup of having heart attack. Now the second question, do his symptoms suggest acute coronary syndrome? Well, he has chest pain, that's pressure in nature, so that's consistent. The duration is long enough, and it occurred early in the morning, and that's when most of men's heart attacks happen. Usually when they wake up in the morning, they start having the chest pain, or actually the chest pain wakes them up in the morning. So yeah, this story is consistent with chest pain that's very likely related to acute coronary syndrome. Location, radiation is important. We have to ask the patients about associated symptoms. Do they have shortness of breath? Were they sweaty? Sometimes nausea and vomiting might accompany chest pains from acute coronary syndrome or heart attacks. Lightheadedness. So these are the kind of things that we want to ask our patients about. What information is needed to determine what type of acute coronary syndrome we have? Is it unstable angina, non-ST elevation MI, or ST elevation MI? So you probably want to look at the EKG to determine whether it's ST elevation MI or non-ST elevation MI. So EKG is important. And then after that, you want to look at the cardiac enzymes to determine whether it's unstable angina versus non-ST elevation MI. All right, so moving on to the next slide. So this goes over these segments that we talked about. If you have someone that comes in with the right setup of heart attacks, right symptoms, you have to divide them into two categories. Do they have ST elevation or non-ST elevation? And the reason we have to do that because the management is different. If you have ST elevation MI, your cardiac markers check will be next to confirm that it is a true MI. If you have non-ST segment elevation, you want to differentiate whether these patients have just unstable angina versus non-ST elevation, and that you differentiate again by using the cardiac markers. If the cardiac markers are elevated, you're dealing with non-ST elevation MI, a true one. If their cardiac enzymes are not elevated, you're dealing with unstable angina. Okay, so moving on. So let's look at this EKG. I hope it's clear enough on the video. So this patient's blood pressure was 158/94, heart rate was 98, respiratory rate was 28. Physical examination remarkable only for S4. What type of acute coronary syndrome is suggested thus far? That's the first question based on that EKG. And the second question, what are the next steps for management? So again, the chest pain, the environment is indicative of acute coronary syndrome. So now our next question, is it ST or non-ST? If we're looking at that EKG, I don't see any ST elevations. So we're dealing with non-ST elevations. So under that category, we have to determine whether this patient has unstable angina or a true or an ST elevation MI, or non-ST elevation MI with elevated cardiac enzymes. So the EKG helped differentiate that this is non-ST elevation MI, and the next steps in management would be giving the patient oxygen, putting them on the monitor, and giving them aspirin. And the preferred dose of aspirin is anywhere between 162 milligrams to 325 milligrams. So baby aspirin is not it. And we prefer to give them the kind of aspirin that they chew, so it shouldn't be enteric coated. After that, if they still have this chest pain, you want to give them something to relieve that chest pain. So your nitroglycerin sublingual and your morphine if needed. And if they still have chest pain, you can put them on nitroglycerin drip. Sometimes we get patients from the ED on nitroglycerin drip because their chest pain continued to be persistent. In the past, we used to give them beta blockers IV, but not anymore. That's not recommended anymore. It depends on the patient. So once you put them on the oxygen, give them the aspirin, the nitroglycerin, the morphine, you want to put them on a heparin drip. And then the beta blockers, you can give them oral beta blockers within the first 24 hours. It's not mandatory to give them beta blockers right away. And the IV form of beta blocker, you give it only if they have tachycardia and hypertension. All right, moving on. So just to recap, the management of unstable angina and non-ST elevation MI is anti-ischemic analgesic therapy. And that's your nitroglycerin, your morphine. Antiplatelet therapy, that's your aspirin, chewable aspirin. Anticoagulant therapy, that's your heparin. And then you do serial cardiac enzymes, the troponin serially that we've done, and we do all the time. And then you have to think about, do I send these patients to the cath lab or not? And that's what the cardiologist will be thinking about the moment we admit these patients. So moving on to the next, that algorithm talks about unstable angina treatment algorithm. You admit the patient, we put them on the monitor, we talked about the oxygen, the serial cardiac markers, we gave him these 3 categories of medications, and the question is, when do we give him Plavix? We give him Plavix if we think they're not going to go to get a heart cath, because that's part of the treatment if you're going to treat him conservatively. If they go to heart cath and you think you're going to stent him, you have to give him Plavix then too. And you also give patients Plavix if they can't tolerate aspirin. If they're allergic to aspirin, you have to give them Plavix. Okay. If you think your patient is going to go to CABG, those are the patients that we don't give them Plavix, because studies have shown if you give them Plavix and they go to CABG, they bleed quite a bit. So that's why we're careful about who do we give Plavix to. So again, the ones that are not going for cardiac cath. The ones are going to cardiac cath and we know we're going to stent them, we have to give them Plavix, and the one that are allergic or intolerant of aspirin. Which heparin we should give them? It's usually Lovenox, more preferred than heparin drip. And it depends on the cardiologist, but for the most part, Lovenox is more preferred. Which patients we should avoid using beta blockers in? The ones who have low heart rate, or blocks, or signs of congestive heart failure, or low blood pressure. Okay? Moving on to the next slide. That just re-emphasizes what we've talked about. You want to avoid, obviously, if you're giving them nitrate for the pain and morphine, you want to make sure that they're not hypotensive, because if they are, you want to be conservative with these. And we talked about the antiplatelet agents. The GP2B3A inhibitors is a decision that will be made by the cardiologist most of the time. Your integralin, some patients will come back on integralin, some patients won't, and that depends on their anatomy and the degree of stenosis. So that will be left up to the cardiologist. But don't panic if you see some of them on it. And these are the kind of options we have for the anticoagulant: the heparin, the fondaparinol, and bivalirudin. So, moving on. So after you give them, after you give the unstable angina patients the anti-ischemic medications, the antiplatelets and the anticoagulant, you have to risk stratify them to see whether they need to go for a heart cath or PCI. If they do, if they're deemed high risk, you take them to the heart cath. The majority of the time, if they have a true non-ST elevation MI, the cardiologist will schedule them for a heart cath. If they just have an unstable angina, they might put them through a stress test first before they take them to heart cath. So the management will be different based on the patient presentation and based on the cardiologist preference. So this is the case one. So the chest pain, after we've treated him for non-ST elevation MI, this patient, chest pain all of a sudden got worse, despite the fact that the patient received nitroglycerin, aspirin, Plavix, and Lovenox. You repeated the EKG, so what do we see right now? So what's the diagnosis and what are the next steps? So there's a huge difference between this EKG and the previous EKG. If you look at V2, V3, V4, V5, and V6, you see ST elevations. So this patient started with unstable angina and non-ST elevation MI, progressed during the hospital stay to ST elevation. So now the management is different. The management is more aggressive and different. What we do, obviously, here we need to call the cardiologist on call for cath, and we need to think about activating the cath lab after we talk to the cardiologist on call for cath. But this patient clearly has ST elevation MI at this point. So now the intervention is not optional anymore. Now the intervention is kind of indicated. So again, for ST elevation MI, whether they develop it in the hospital or they come in with it, you also have to admit them, put them on EKG monitor, give them oxygen, do the serial cardiac enzymes, and use the same categories of drugs: the anti-ischemic analgesic agents, the antiplatelet agents, and the anticoagulant agents. Are these medications different than in the previous case where we were treating unstable angina and non-ST elevation MI? Typically, they're similar drugs but at higher doses. Okay, and then you want to obviously plan right away for PCI or cardiac catheterization. So moving on, what are the goals of ST elevation MI management? Your number one goal is to open up that clogged artery. Why? Because time is muscle. The longer you sit on that clogged artery, the more myocardium and muscle you lose. So we need to get them into the cath lab right away. So the goal is to restore blood flow to infarct artery. So that's what we call reperfusion. And that helps because once you open the artery, you limit the area and the size of that infarct and the damage to the heart. So that's why time is muscle. That's why we have door to balloon time of 90 minutes, because we want to open up the artery as fast as we can. What options do we have available to open the arteries when they're clotted or clogged? You either do the percutaneous coronary intervention, which is your cath and stenting, or ballooning, or you have thrombolytics, or you have cabbage. So which one do we really use? As you all know, looking at the second slide, or next slide, your main intervention will be invasive reperfusion. But the question is, if you're in a hospital that's not available, what do? So look at this algorithm. If you have ST elevation MI, you're gonna immediately work on reperfusion or taking them to cath lab and opening that artery up. So if the answer that you have the capability, it's a yes, you take him directly to the PCI. That's what you see on the right side of this. But if the answer is no, like you're in a hospital that doesn't have that capability, then the next question would be, can I transfer him to a hospital that has that capability within short amount of time, like within 30 minutes? If the answer to that is yes, you send him to that hospital and do nothing else. If you can't, and if you don't have a hospital that has the capability of doing a heart cath and ballooning and stenting, then you think about giving them the thrombolytics. And then that takes you to a different set of questions. Do they have the ability and the contraindication for thrombolytics? If they do, then you just don't treat them and treat them conservatively. If they don't, then you give them thrombolytics if they don't have any contraindications. The next couple of slides talk about which one we prefer, PCI and versus thrombolysis. In our hospital, we do PCI because we have the capability, we have the team, we have the cath lab, we have the physicians that can do it. So the rest of these two slides will be more of an academic discussion. In our hospital, take him to the cath lab within hopefully 90 minutes. So after we put a stent in them, what do we keep him on? We keep him on the aspirin. Actually, no, scroll back up. It's therapy after reperfusion slide. Yeah, so we keep him on aspirin. We keep him on either Plavix or Brilinta. That's what you're going to see the most in our hospital. Heparin potentially, IV nitroglycerin potentially. We give them beta blockers if they're not bradycardic or in shock. We give them ACE inhibitors if they're not in shock. So these are the things that you expect to see your patients after stenting, after heart cath. You expect to see the patients on. The majority of the time, their heparin will be stopped by the cardiologist, but sometimes they keep them on if they have persistent pain. But these are the things that you expect to see. So going back to that patient was taken to the cath lab. They found an LAD lesion. They stented it. The patient after that developed dyspnea, rales, and became hypoxic 1 day later. So a day after, he did the first day he did just fine, and the day after he developed these symptoms. So he was short of breath. He started dropping his SAT, and he had rales on exam. His blood pressure was 106/60, heart rate 70, respirator 24. What is the complication here? What are the next steps to treat this complication? What interventions are appropriate if blood pressure dropped to 88/55 instead of the 105/60? So let's go through that. So these symptoms, as you know, are consistent with congestive heart failure or pulmonary edema from congestive heart failure. So that's the problem that we have here. And you can obviously order a chest X-ray and keep an eye on their pulse ox. What can cause congestive heart failure after a heart attack? Well, maybe the damage from the original heart attack is too much and put the patient in congestive heart failure. So that's one of the options. The other option, maybe the stent occluded. So we put the stent in, but the patient clotted the stent. So that can give you congestive heart failure. Or maybe after the heart attack, you have valvular dysfunction, like acute mitral regurg. So if you have heart attack and the left ventricle, that might mess up the anatomy and might give you a day later acute mitral regurg, and that would look like or manifest as congestive heart failure or pulmonary edema. So these are kind of the three things that should go through your mind, and the treatment is obviously different. If there's damage from the heart attack, You continue to treat it medically, and that includes your beta blockers, antiplatelet, heparin, and then if their blood pressure is high, you bring it down by either giving them nitroglycerin, nitroprusside, if the beta blockers didn't work. If their blood pressure is low, you have to think about other methods of supporting them. Obviously, you give them Lasix. We all know with pulmonary edema, congestive heart failure, we give them Lasix. So you're gonna give them Lasix, you continue the medical treatment if you think all of their symptoms are related to their heart attack. All right, what if their blood pressure was low? If their blood pressure is low, then we call the cardiologist and we discuss with them, is this patient a candidate for intra-aortic balloon pump? Can we put him on inotropic support agents like milrinone or dobutamine? Can we put him on vasopressors like Levophed? And then consideration for CABG comes, the cardiologist will handle that. All right, so moving on, the EKG, this is a case study number 2. It's a complication, just to go over what can go wrong after a heart attack. This EKG is obtained in a patient with chest pain and a blood pressure of 90/50. Jugular veins are distended, but lungs are clear. So if you look at this EKG in leads 2, 3, and AVF, you clearly have what looks like ST elevation MI, because you have ST elevations in these 3 leads. So we know we have an ST elevation MI. And it's in the inferior lead, so very likely this ST elevation MI is at the expense of the right ventricle. So the right ventricle is infarcting. So what do you do when you have right ventricular infarction? What you do, because that can cause cardiogenic shock, what you do, you give them a lot of fluids. The right ventricle is very sensitive to fluid. You have to fill the right ventricle in order for it to work better if you have a heart attack in it. So you have to give them fluids, and you have to think about inotropic support like dobutamine and milrinone. And then if that doesn't work, you have to consider assist or support devices, and that the cardiologist will handle that. You can give them diuretics if they start filling up with fluids or nitroglycerin. But for the most part, the majority of the time, if you have right ventricular failure in association with heart attack, you have to give them a lot of fluids. Okay, let's look at this next complication. Case study number 3. 72-year-old man got a hip replacement 3 days prior, transferred to the ICU with palpitations and shortness of breath. His blood pressure is stable. Pulse ox 96% on 2 liters, and chest CT angiogram is negative. And you're looking at his rhythm. What might be the cause of this change, and what should be done about it? So that's the EKG, and if you look at the waves or waveforms, you can appreciate that it's a seesaw pattern, right? And when you see that, you almost always think about atrial flutter. It's a seesaw pattern that's after what looks like potentially a heart attack. You recognize this as atrial flutter. What can cause this? Well, this patient has hip replacement, and we all know that these patients are at a higher risk of developing clots in their legs and clots in their lungs. So PE can do that. What else can give you arrhythmias in general and atrial flutter in particular? Electrolyte abnormalities, low potassium, low magnesium, or a heart attack, perioperative MI. So we have to send their troponin, we have to send their lights, and we have to consider ruling them out for PE. Those are the patients that we deal with all the time on the surgical side. And moving on to the next slide. Perioperative myocardial infarction usually happens after you perform a surgery, like either an abdominal surgery or a hip surgery. Usually happens on third postoperative day. So if you notice any changes in their blood pressure or any chest pain or shortness of breath or arrhythmias, you have to consider MI in patients after surgery. And it usually is a typical presentation, so they might not come and tell you, I have chest pain. They might say to you, oh, I have some nausea, and you notice some arrhythmias on the monitor. So just keep an eye out for heart attacks on post-operative day 3, where the patient isn't going to come with the appropriate or with classic symptoms of a heart attack. So you have to initiate the same medications: aspirin, Plavix, nitrates, heparin, beta blockers if indicated. And if they have ST elevation, you have to consider obviously heart cath. So EKG, get the EKG, put them on the monitors, do the same things that we talked about earlier. All right. So what are some of the challenges that we go through or we have to consider? We talked about the aspirin allergy. If the patient has aspirin allergy, you could put them on Plavix, okay? Or Berlenta, obviously. What if they have coffee ground emesis? What do you do about that? You might have to avoid, if they have like GI bleed, avoid aspirin, heparin, and some of the other medications, particularly thrombolytics and integralin. But you can get away by using bilirubin, so there are options, or heparin drip, because it has short half-life, you can reverse it. So we can still trial heparin drip on patients who come in with heart attacks that has some GI bleed. If the GI bleed is not excessive or overt, we can still use heparin and monitor their HNHs and their bleeding. So how about patients with severe heart failure exacerbation? So these patients, putting them on beta blockers might be tricky, or even putting them on ACE inhibitors. So you want to avoid beta blockers if they have clinical heart failure, if they're really out of breath, pulmonary edema. So you want to avoid beta blockers. And if their blood pressure is low, you want to avoid ACE inhibitors. What if they have renal failure? Can I put them on Lovenox? Well, maybe you want to avoid that or adjust the dose. You can put them on bilirubin or obviously heparin drip. But just make sure that if they have kidney failure and you want to put them on Lovenox, you adjust the dose. All right, so that's the end of our lecture. I hope you guys have learned, and if you have any questions, please ask your cardiologist or the intensivist. They would be gladly happy to do it.